Welcome back to the cardiovascular system. We're picking up now where we left off with paths of circulation. And so with the paths of circulation, you're going to have two paths that the blood travels through within the body. The first path we're going to discuss is going to be referred to as the pulmonary circuit. So this is where the path of blood vessels are going to carry the blood from the heart to the lungs and then back to the heart. The second path is going to be referred to as the systemic circulation. And so the easy way to think of this one is that it's going to take blood to all over the body or all the systems in the body. And so this is the path of blood vessels that carries blood away from the heart to all body parts and then back to the heart again. And so with these two, we're going to look at it viewing a diagram and a picture so you better understand. So here's a picture that's going to show you both paths of circulation. So what happens is, you have your vena cavas, the right and left vena cava is going to, not right and left, but inferior and superior vena cava is going to come in here to the right atrium. From the right atrium, it's then going to go through, you see the small valve here, which is going to be your tricuspid. From that tricuspid, it goes into the right ventricle. Then when that ventricle contracts, it's going to push up, and then it's going to exit through the pulmonary valve. From that pulmonary valve, it's going to go through the pulmonary trunk into the pulmonary arteries and make its way to the lungs. There, it's going to diffuse the carbon dioxide across the alveoli and pick up oxygen. That oxygen now is going to enrich that blood, so you take the oxygen-rich blood from that capillary bed through the veins, and these are going to be your pulmonary veins. They're going to make their way back to the heart. It's going to come in here to the left atrium. When the left atrium contracts, it goes through this valve here, which is referred to as the bicuspid valve or the mitral valve. It goes into the left ventricle. The left ventricle contracts, and it's going to come up through this valve here. This is going to be your aortic valve. From the aortic valve, it enters the ascending aorta, comes around this section, which is the aortic arch. That will feed the head and the upper limbs. It also can then dive down deep and go into what's known as the descending aorta. And that descending aorta can be divided up into further parts too. They're all part of the descending aorta, but it could be part of the thoracic aorta or go down further into what's known as the abdominal aorta. And so from there, it's going to go down and it's going to feed the parts of the body or the tissues. Now, once it gives its oxygen-rich blood mix it to those tissues, it's going to give up the oxygen into those tissues. It's going to pick up carbon dioxide, and then that carbon dioxide is going to make its way back to the heart through either the inferior vena cava or the superior vena cava, and then it's going to make its way back into this right atrium again. So here is just a diagram of the route that blood takes throughout the heart and through the body. So we're going to come in through the vena cava. From the vena cava, it's going to go to the right atrium. The right atrium then goes through. Remember, you're going to have a valve here. So right here, it goes through the tricuspid valve into the right ventricle. Right ventricle contracts, goes through another valve, which is going to be the pulmonary valve, then goes into the pulmonary arteries. Remember, arteries always pump away from the heart. Veins always go towards the heart. So the pulmonary arteries are going to then take it to the lungs. Here, it's going to let go of the carbon dioxide, and it's going to pick up oxygen at the alveoli. Comes back in through the pulmonary veins into the left atrium. The left atrium contracts. It's going to go through what's known as the bicuspid valve or mitral valve, depending on what text you're using, into the left ventricle. That left ventricle then contracts, and it's going to go through the aortic valve. That aortic valve will take it to the aorta. From the aorta, it goes into the arteries, which are going to feed it to all the tissues in the body. The arteries go into smaller and smaller vessels, which are going to be arterioles and eventually capillaries. Capillaries are going to allow that oxygen to diffuse across into the tissues. It's here where it's going to pick up the carbon dioxide, and it's going to take that into small veins called venules, and then into the larger veins, which then make their way back to the vena cava. So here you're looking at simply a different version of the diagram. And so, let me get my again. And so here we're going to come in through the vena cava. That's the superior vena cava or the inferior vena cava. Both of them come into the first step, which is going to be the right atrium. From the right atrium, it will contract, go through the tricuspid valve. Notice you see the cords coming off. That is the chordae tendineae. They are attached to these little muscles here, which are papillary muscles. So it comes from the right atrium into the right ventricle, which is going to be part 2. The right ventricle will then contract and sends this blood up through that pulmonary valve into the pulmonary trunk. Kind of looks like a T. Think a T for trunk. It's then going to split 2 ways. It's either going to go to the right or to the left. So if it makes its way to the right lung, it's going to be the right pulmonary arteries. If it makes its way to the left lung, it's going to go to the left pulmonary arteries. Remember, in anatomy, your rights and lefts are always flipped because you're assuming that this person is looking at you or they're laying on the table, and so it's going to be opposite of what yours are. And so it made its way to the lungs. It's going to pick up oxygen, get rid of its carbon dioxide, and it's going to come back to the heart. It's going to come back to the heart through pulmonary veins. So we see it coming back from the left lung here into the pulmonary veins, or from the right lung here into these pulmonary veins. The pulmonary veins then deposit themselves into the left atrium. It's going to go through, once it contracts, this valve here, which is going to be the mitral valve or bicuspid valve, into the left ventricle. That left ventricle contracts, goes in through the aortic valve. From the aortic valve, it goes into the aorta. Now, this is referred to as the aortic arch, where it kind of arches around. Blood can go up through these arteries here and feed the neck and the limbs, or it can continue to dive deep, where it's going to feed the rest of the body, the trunk and the lower limbs. It's going to deposit that oxygenated blood to the tissues, pick up carbon dioxide, and then you see it here for step 10, making its way back to that right atrium. And here's just another picture of what we've been discussing, what goes on, going through the pulmonary circuit, which is to the lungs and back, and then the systemic circuit, which is going to be to the body's tissues and back, or to the systems and back. With coronary circulation, the coronary arteries are going to deliver oxygenated blood and nutrients to the myocardium. Remember, the myocardium is going to be the muscle that makes up the heart. That's going to be what's doing the pumping. And so you would think with all the blood that's going through the heart, it would get plenty of oxygenated blood and could get rid of its deoxygenated blood very easily. But it does not use that circulation going through the inside of the heart to do this. Instead, it's going to have its own circulation, or it has its own arteries and veins that are going to go through the outer portion of the heart to actually feed the heart and then take away the waste. And so with these, we're going to have branches that are going to rise off of the aorta as it comes out of the left ventricle. And you're going to see those coronary veins remove carbon dioxide and waste from the myocardium or the heart muscle. And these branches are then going to converge in at the coronary sinus, which empties into that right atrium, kind of near where the superior vena cava would come in. And so here you can see that right there you have the opening of the left coronary artery. It's right there at that aortic valve. And so as it comes up to that aorta, it's going to actually have branches of the arteries that are coming off there, and they're going to wrap around the outer portion of the myocardium, and that's how it's going to get blood to feed the myocardium. Here, this is going to show you the major arteries that are going to the heart to feed the heart. And so we have the right coronary artery that you see, which is coming out around the edge of the heart, and then notice how it branches off into smaller and smaller arteries. And then you have the left coronary artery. Then it goes off to the side, and that sideways or transverse vessel that's going around towards the back is going to be referred to as the circumflex artery. And so then it comes down further from that left coronary artery and goes into what's known as the anterior interventricular artery. And you see how those will go in. Very lightly, these are going to be arteries towards the back. Those are referred to as the posterior interventricular arteries. And the reason that they're lightly shaded, because it's like you're looking through the heart, and the heart's translucent. So here's another view of the heart, and this one actually adds in the cardiac veins with the arteries. So remember, they always run along with the arteries, because wherever you're depositing nutrients, you also need to pick up the carbon dioxide and waste products. And so with this, you can see how you have the anterior interventricular artery going along with what's known as the great cardiac vein. Over to the left-hand side, which is actually the right-hand side of the heart, you'll notice that you have the right coronary artery and your atrial arteries, and along with that, you'll have anterior cardiac veins and then small cardiac veins going along with it. Now, with these, one of the major diseases or major health problems that we have today is known as coronary artery disease, or often referred to as CAD, C-A-D. So if you see that in any quizzes or any test, notice that that is one of the major health conditions that we have today, coronary artery disease. Right. So looking here, with the anterior cardiac veins, you see how you'll have some of them that are going to be very light. This is also a translucent version of the heart again, so you're looking at the ones that run across the back of the heart. And remember that coronary sinus is going to be the one that actually empties into that right atrium. And here's a look at those vessels at the back side of the heart. You notice this is the back side of the heart because you see on here that you have your large vessels that are coming out the back, and you don't have that interventricular septum that would normally run through the center. Instead, you see you have two of those major arteries and veins running along the side there. The marginal artery that's running along there, and then you see another marginal artery, and then of course you have your middle cardiac vein and posterior vein of that left ventricle there. Now, talking about CAD, that coronary artery disease, it is actually going to be where you have some sort of blockage that's going to be within the arteries of the heart. Here's showing you an actual heart that has been injected with, it's actually turned into fiberglass, or sometimes they'll also inject it with a rubbery type material that will go into the vessels. Now, when you're talking about coronary artery disease, if you look over to the left-hand side, you'll see what's referred to as a normal artery. Notice how it's nice and open. There's nothing there blocking the flow of blood that's coming through this vessel. If you look at the cross-section, it's a transverse section. You can see it's nice and open. There's a nice open lumen. Lumen's going to be the hole or the opening that goes through the center. If you look over to the side here on the right-hand side, this is going to be a narrowing of the artery. So notice that there's going to be a buildup of plaque that you're going to see here that's going to be between that muscular tissue of the artery and that outer tunica of the artery. So that tunica media and then the tunica intima, which is going to be the inner layering, is going to be separated with this fatty plaque. And that fatty plaque over time can actually go in and it can harden, and it can make it so it basically won't be cleaned out, or it won't go away once it hardens into a stiff plaque there. And that narrows that lumen and makes it hard for blood vessels and things to go through. So eventually you will end up sometimes with a full blockage, or this one right now is a partial blockage. And so it's prone to different types of blood clots, and those could be very dangerous. In order to go around these, lots of times you would have a coronary artery bypass graft. And so basically what they're going to do is they're going to go around that section that's been blocked. And so they'll attach that into a major artery and they'll run it around. So if you had a blockage, let's say somewhere a little bit further up, then they'll run this line in right below it and they'll attach it in there. That way it can still feed that section of the tissue and it won't be oxygen starved. So a single bypass is what you see on the first one. A double bypass is where they're going to go in and they're going to go around 2 different blockages. A triple bypass goes around 3, and a quadruple 4. And so you can keep going up and have many, many bypasses. But this is what they're basically doing when they're doing a bypass. They're taking it directly from a major artery. They're bypassing the blocked portion and going right behind that blocked portion so they can continue the feeding of that myocardium. There's another thing that they could do where they go in and they'll put a stent in. And the way they do this is that they'll send a catheter in, and that catheter is going to have a mesh substance that it's going to be attached to with a balloon. So once they get to the area where the blockage is, they'll inflate the balloon, which causes that mesh stent to open up. Once it opens up, they'll then deflate the balloon and they'll pull that catheter out. And so that mesh stent will help keep that area open and allow blood to flow through normally. Right here, you're looking at cardiac muscle tissue. You know that this is cardiac muscle tissue for several different reasons. If you look really, really close, it's going to be what's referred to as a striated type of cell or muscle. That means it's going to have light sections and dark sections. They basically are bands or look like stripes that are going to be found within this type of muscle cell. Striations are also going to be found in skeletal muscle. Another thing that you notice, if you look at all the arrows here, they're pointing at dark lines or dark sections. These are going to be the intercalated discs. These intercalated discs are going to be made up of gap junctions. These gap junctions will allow substances and electrical currents to flow from one cardiac cell to the next. Also looking here, you'll notice that each cell is made up of one nucleus, so it's going to be what's referred to as a uninucleate. If it's skeletal muscle, it would have multiple nuclei per cell. Also, you'll notice that it has some branching. It's not completely cylindrical, but it'll branch off and go in different patterns. And so you'll see some branching right here. You can see some branching right here. And so that's often referred to as bifurcated. So these will be bifurcated cells or branching cells that go off in different directions. The adjacent muscle cells, like we said, are going to communicate through these gap junctions. And if you look at that cell within, you'll see the different parts that you normally see within a muscle cell. And so the sarcolemma is simply going to be the cell membrane that goes around a muscle cell. Instead of having cytoplasm, it's filled with a substance called sarcoplasm. And through the center you see attached to that sarcolemma, you're going to have what's known as a transverse tubule. That transverse tubule is then going to be attached to that sarcoplasmic reticulum there. And so that also you will hear as being referred to as a T-tubule. And so that's going to allow ion concentrations to come down. And as it comes down, it also allows for the electrical signals to come down as it depolarizes and repolarizes, which will then cause a contraction. Now with all muscle cells, you'll notice that it has quite a few mitochondria. As muscle cells need a lot of energy, that's what these mitochondria do. So they'll help produce the ATP or the energy that's going to run the cell. Now you can see the banding is actually going to be created by the thick filaments and the thin filaments. So the thicker filaments, which are made of myosin, are going to actually be the darker sections that you see there. The thinner filaments are going to be made of what's known as actin, and that's going to be the lighter band you see there. And the actin, of course, is going to be attached to each other in a zigzag line that comes down, and that's referred to as the Z disc. Here you can see these bifurcated cells are the ones that kind of branch off in different directions. You'll see that intercalated disc going through the center. Notice how there's going to be one nuclei per cell and many, many mitochondria, along with banding or striations. The cardiac conduction system is going to be composed of special cardiac muscle fiber cells that are going to be called autorhythmic fibers. So these cells are going to be self-excitable and they're able to generate action potentials which contract that heart. And so they're going to be able to cause their own contractions, cause their own excitability and action potential or nerve impulses that are coming through. They don't have to be controlled from the central nervous system. The SA node, or what's known as the sinoatrial node, is going to be the pacemaker of the heart. So this is going to be located in the upper portion of that right atrium. So these specialized cardiac muscle cells are going to be able to generate electrical signals that are going to then cause the atria to contract. So it's going to set the pace of the heart, hence the name, the pacemaker. The AV node, or atrioventricular node, is going to be a group of slow, small fibers that are going to be located in the septum that's separating that right atrium and the right ventricle, and it's going to transmit the signal to the bundle of His. The AV bundle, or bundle of His, is going to be a bundle of branches. These are large, fast fibers that are going to be located in the septum. They're going to transmit signals to what's known as the Purkinje fibers. The Purkinje fibers are then going to transmit the signal to the ventricular muscle, and that's going to cause that ventricle to contract. And so here is a visual of what everything we just said. So starting with the pacemaker, the SA node or sinoatrial node, that's going to generate that first impulse. That impulse is going to travel across from the right atrium to the left atrium and cause them to contract together. The impulse is then going to pause for about 1/10 of a second at that atrioventricular node. Then the AV bundle is going to connect the atria to the ventricles, and it's going to send that signal down through the bundle branches. Those bundle branches go down through the septum of the heart between the two ventricles, and then it's going to actually split apart and go up the Purkinje's fibers. So notice that these bundle branches, that's going to be your bundle of His, and then it's going to come down and it splits apart and it goes up the sides of the ventricle. So that's going to cause a contraction of the entire ventricle on both sides. So autorhythmic fibers in that SA node are going to be the natural pacemakers of the heart because they're going to initiate the initial action potential or electrical signal that's going through the heart to cause the contractions. So signals from the nervous system and hormones like epinephrine, they can help modify the heart rate and the force of contraction, but they do not set the fundamental rhythm. That's just going to be that SA node or that pacemaker. And so looking here at this heart, sometimes the SA node doesn't work properly or the human pacemaker doesn't work properly. And so it might actually be a very slow heartbeat, which is known as bradycardia. And sometimes it's going to be a very fast heart rate, which is known as tachycardia. And so if the heart doesn't set the correct pace, then the person could, the heart might be going too fast, it might be going too slow, or it might be going in random rhythm and not working together. So they might go in and put an actual man-made pacemaker in. And so what they do on the right-hand side, they would put the actual battery-operated pacemaker. Then they would send a pacemaker lead down through that superior vena cava into the right atrium. And notice how it does have a lead that goes into that right ventricle there. And so that's going to be battery operated. You would have to go in and have those batteries replaced every like 4 to 5 years, unless of course they start making batteries that last longer. But right now, as far as I know, it's around every 4 to 5 years they'll go in and they'll replace these through a surgery. And so that will set the pace of the heart and keep the heart working properly. Now, in order to measure that heart rate and to see if the heart's working properly or to see if there's certain damage to parts of the heart, you could go in for what's known as an EKG or an ECG. So electrocardiogram is what you would go into. And so this is basically a recording of the electrical changes that accompany each heartbeat. And so you have what's known as the P wave, and then you go to the QRS wave. You'll have a straight segment, which is going to be in between, that's the ST segment, and then you'll have your next wave, which is called the T wave, and then you'll have a flat line until it gets back to the P wave again. And so this is a picture of how sometimes they'll set up a test where they're going to measure these. And so what these EKGs will allow us to do is it's going to allow us to determine if the conducting pathway is going to be normal in the heart, or if there's some type of damage or some type of deformity that might be there from birth. It also lets us know if the heart's enlarged. It lets us know if certain regions of the heart are going to be damaged, and the cause of chest pain if you've gone to the doctor complaining of chest pain. And so here we're going to see how that electrical influence goes through the heart. We start first with the SA node. Remember, in the right atrium, it travels across to the left atrium, and it's yellow, so that's going to be the depolarization there of the atrium starting at the SA node. This is what causes your P wave, that depolarization. As it travels across the atrium and down, it hits that AV node. That's going to be that little pause between the P and then the Q. Then you see repolarization of the atrium and depolarization at that bundle of His as it's coming down the center septum of the ventricles. This is going to be your QRS wave that's going to cause this, or that you see. All right, so once the septum, or the bundle of His, has become depolarized and it's gone up the Purkinje's fibers. So now both ventricles are completely depolarized. This is where you're going to see the flat line again between the S and the T. Once it starts to repolarize, starting at the apex of the heart and working its way up, that is going to be your T wave. And then eventually you'll have complete repolarization of the ventricles, and that's going to be the flat line between the T and the P wave. And so looking here, you'll see a normal sinus rhythm above. The one below is going to be what's referred to as a junctional rhythm. And so here is going to be where the SA node is going to be non-functional. So P waves are going to be absent here. And then the AV node is going to pace that heart, and it makes it about 40 to 60 beats per minute here. So you have no P wave. That tells you problems with the atria or the SA node not working properly. This one that you see up top is your ventricular fibrillation. These are going to be chaotic waves. They're very irregular when they're doing an ECG or EKG. And this is going to be seen in acute heart attack or an electrical shock. The picture above is going to be what's known as bradycardia. That is a very slow heartbeat. Notice that with each box, it is going to be a measure of time. And so each of these sections here, each 5 blocks, is going to measure about 0.02 or 0.2 seconds. The bottom picture is going to be referred to as tachycardia, and this is going to be a very fast heartbeat. Next, we're going to go into heart physiology. And so how is this occurring? So with the heart physiology, you're going to have what's referred to as a cardiac cycle. This is when both atria and ventricles are going to contract and relax. So once both of those things have occurred, that's going to be referred to as one cardiac cycle. Systole is going to be when either the atria or the ventricles contract. Atrial systole is going to be the atria contraction. Ventricular systole is when the ventricles contract. Diastole is going to be when either the atria or the ventricles relax. So atrial dystole is atria relaxation. Ventricular dystole is going to be when the ventricles are going to relax. When you listen to the heart, you often hear the dunk, 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 dunk sound. That is going to be often referred to as the lup-dub sound. And so these are going to be the sounds that are going to correspond with the closing of the AV valves. That's going to be the lup sound, and you do need to know this. The closing of the pulmonary and aortic valves, or what we refer to as the semilunar valves, is going to be the dub sound. So AV valves, lup. The semilunar valves are going to be dub. So lup, dub. And so looking here at this picture, notice how that both of the atrioventricular valves on the upper picture are going to be open at the same time, and the semilunar valves are both going to be closed. And then when the AV valves close, notice how the semilunar valves open, and that's during the contraction of the ventricles. So with a cardiac cycle, one cardiac cycle consists of the contraction or systole and the relaxation or diastole of both atria, rapidly followed by the systole and diastole of both ventricles. They do have electrical events that you're going to be able to see. They do have pressure changes that you're going to be able to measure, and they do make specific sounds like those lup-dub sounds. And then you'll have volume changes. You also have mechanical events that are occurring. And so with this, the electrical events, the first electrical event, remember, happens at atrial systole. And so that's going into that P wave. Then it's going to come down. You have a rest for a second. And then you'll see the ventricular systole. Then you'll see the relaxation period. And so here's what the pressure looks like as it's going through here. And so during atrial systole, that pressure in the atria is going to increase. That's the green line that's going to be on here. During ventricular systole, the pressure in the ventricles will increase, and that's what you're going to see in the blue. And then during relaxation periods, both the atria and the ventricle pressure will diminish. So notice how the green and the blue both go down. With the heart sounds, there are actually going to be 4 total heart sounds, but usually you only hear 2 with a stethoscope. A very well-trained nurse or doctor who is able to hear all 4 will be able to do this very easily once they get used to these sounds, but they're very, very light. And so the S1 sound is the LUP sound. That's when the AV valves or atrioventricular valves are going to be closing. The S2 sound is going to be the dub sound, and that's when the semilunar valves are going to be closing. Now, those are the 2 that everybody can usually hear through a stethoscope. The other 2 sounds are going to be the S3 sound, which is going to be blood filling in the ventricle. That often is not heard. And then the S4 sound is going to be blood ejecting during atrial systole. And again, that one's not often heard either. So if you want to listen to different sounds in the heart, you also might notice that when you go to the doctor and they're listening for these sounds, they'll move the stethoscope around your chest and they'll listen as you're just breathing normally. And so if they're listening to the aortic valve, that sound's going to be heard at the second intercostal space at the right sternal margin. So you find the sternum, which is the center in the chest, and then you go over to that second intercostal space. So that's going to be between the second and third rib. If they want to listen to the pulmonary valve, the sound is going to be heard at the second intercostal space at the left sternal margin. And so you're going to be found between the second and third rib, and it's going to be on the left-hand side. If they want to listen to the mitral valve, this is going to be heard at the heart's apex, and that's going to be in the fifth intercostal space in line with the middle clavicle. And then if you want to listen to the tricuspid valve, that sound's typically going to be heard in the right sternal margin of the fifth intercostal space. Now with volume changes when everything's going on, you can see how it's going to change throughout the different occurrences that are happening. So if it's atrial systole, notice how the pressure is going to be up slightly. Then when it goes into ventricular systole, notice how it's going to drop down. And then during the relaxation period, notice how it starts to go back up a little bit. And with those mechanical events, what's actually happening? So with the atrial contraction, notice how the atria is pushing blood through those AV valves into the ventricles. With the isovolumetric contractions, that's when the ventricles are going to start their contraction. So it's going to close the AV valves and is going to get ready to open up the semilunar valves. Now, ventricular ejection is when it completely contracts, it pushes those valves open, and then it goes into those major vessels. The isovolumetric relaxation is going to be the relaxation of that area. You're also going to see blood coming in and start to fill its way into that right atrium. Then you have ventricular filling, where it's actually going to go into the ventricles again, and then the atrial contraction where it completely pushes out all the blood from the atria into the ventricles. And then this is simply just another view of what's going on within the heart during these periods. Now, cardiac output is going to be what we refer to as the volume of blood that's going to be ejected from the left or right ventricle into the aorta or into the pulmonary trunk each minute. Stroke volume, often referred to as SV, is going to be the amount of blood pumped out of the ventricle in one beat. So CO is going to be each minute. The SV is going to be each beat. And so in order to figure out total cardiac output, you can do the SV in milliliters per beat, and then the heart rate by beats per minute to help figure out that cardiac output. So several factors are going to help you regulate your heart rate. You have what's called autonomic nervous system. That's going to actually work with your parasympathetic nervous system. That's the one that controls just your daily functions, sitting around watching TV, eating dinner, doing your daily activities. That's going to be able to lower the heart rate. The sympathetic nervous system is going to be the one that you're going to have kicking into gear when you're under stress or in a fight or flight response. That is going to speed up the heart rate. Hormones can also do this. So you can have things such as epinephrine, norepinephrine, or even thyroid hormones, which can go in and speed up the heart rate or lower the heart rate. Different ions and their concentrations can also help regulate the heart rate. So sodium, potassium, and calcium are going to be the major ions that are going to help with these muscle contractions. Age is going to be a big factor in it. the heart will beat at a very high rate as an infant and then start to slow down as you get older. And so it continues to decline with age. So when you're 80, 90 years old, you will have the slowest heart rate of your life. Gender also affects this. Females often have a higher heart rate than males. So the heart will beat faster in females versus in males. Physical fitness is also going to have a lot to do with the regulation of the heart rate. So the more physical fit you are, usually the lower the heart rate is. The less physically fit you are, the higher your heart tends to beat because it's under a lot more pressure and it's got a lot more work that it's doing. Temperature can also be a major factor. The higher the temperature is going to increase the heart rate. Lower temperatures will tend to decrease the heart rate. So going in, adding in the nervous system and with the heart, you have the vagus nerve, which is going to be part of your parasympathetic nervous system, which is going to be able to come in from the spinal cord, and actually it attaches in at the SA node and the AV node, and that can actually go in and help to decrease the heart rate. With the sympathetic nervous system, your fight or flight, you have the sympathetic cardiac nerves, and they're going to increase the heart rate and the force of contractions. And they come in, notice how they can attach to the AV node and the SA node and go in and attach to the right and left ventricle. All right. So when the brain is processing what's going on, input to the cardiovascular center. So it's going to take in information to the higher brain centers. That's going to be the cerebral cortex, the limbic system, and the hypothalamus. If it's bringing it in from the sensory receptors, you have what's called proprioceptors. They monitor movements. You have chemoreceptors, which monitor the blood chemistry. And you have baroreceptors, which are going to monitor blood pressure. Now, once you have the brain functioning with that, you have output of the heart. So you have the cardiac acceleration nerves, so they're going to increase the rate of spontaneous depolarization of the SA node, and AV node is going to increase heart rate. You have increased contractility of the atria and ventricles, which is going to increase the stroke volume. The vagus nerve can come in part of the parasympathetic nervous system, and it can decrease the rate of spontaneous depolarization of the SA node and AV node, which will then decrease the heart rate. And then factors that can increase cardiac output. So you could have increased preload. Let's say within limits of cardiac muscle fibers, they're going to contract more forcibly, stretching. That can lead to increased stroke volume. You could have increased contractility, which can lead to increased stroke volume. And you could have decreased afterload, which could lead to that. Both of these can go to increased cardiac output. Of course, with your heart, you should know that regular cardiac or aerobic exercise is going to be good for the body. It will help increase your cardiac output, so the more that your heart can put out at a time, the healthier it is. It leads to increased HDL, or high-density lipids. These are going to be the good cholesterols. These are going to be the ones that help to regulate and clean out the bad cholesterols, which are the LDLs. It can decrease triglycerides that are going to be found in the blood and improve lung function. Also, it decreases blood pressure, assists in weight control, and overall helps the body. If you can't bring some of these things down or increase the cardiac output, it could cause the heart to work harder, which would then, since it's a muscle, increase its size. And we all know with an enlarged heart, it becomes less efficient, and eventually you could end up with a heart attack or need a heart transplant. Okay, so that's going to finish us up for the heart unit, and I will see you back with our next unit.